Hello, everyone, and welcome to the BPHASA and the ARC Michigan PCP webinar series. Your cameras are turned off and your microphones are muted, but please use the Q&A function if you would like to ask questions to our presenter today. The webinar presenter may answer your questions during the presentation, or they may wait until after the presentation to respond to you via email. And following today's webinar, you will receive an email with a link to the recording, as well as I will send a follow-up email with a PDF of today's presentation and a link to our website where you can find previously recorded webinars. And that is all I have. Thank you all for attending. And we'll give everyone just a few more seconds to get logged in. It's just a little after 3. And then I will turn it over to Lindia, and she is going to present to us today on the update from the state of Michigan.
Heather, do we want to wait a little longer, or am I good to get started?
It's about 2 minutes after. We can go ahead and get started, and people can just trickle in.
Okay, sounds good. All right, well, I will go ahead and get started. So as Heather introduced me, my name is Lindia Duramity, and I'm the manager of the federal compliance section that is within the Bureau of Specialty Behavioral Health Services. So my update today is really just going to focus on our HAP waiver renewal and our 1915 iSPA amendment, which the federal compliance section oversees. So I'm hoping to give you all an update in terms of where we are with that process, what we changed in the HAP waiver renewal, and what amendment changes we made in the 1915 iSPA. So Heather, if you're good, you can proceed to the next slide.
Sorry, I'm having some technical difficulties.
This would have been me if I had the slides. So I think I would have done the same thing. Technology has not been my friend these last couple of weeks. So.
There we go.
You know, I'm going to try and start by memory while she gets to the next slide. So let's see how this goes. So I think the next slide is going to move toward the habilitation supports waiver. It's actually going to just talk about what I'm going to talk about today, which is the habilitation supports waiver, or HAP waiver, or you'll hear HSW also referenced for this. We have our amendment renewal, which our current HAP waiver application is due to expire at the end of this month on 9/30/24. And then we also have our 1915 iSPA amendment, and that is also the other thing that I'll talk about, and that aligns. The reason why we were doing the amendment for the 1915 iSPA was not only just to get in some changes that we wanted to make, but also to align with the changes we made with the HAB waiver and the other 1915C waivers, which are serious emotional disturbance waiver and our children's waiver, which are both waivers that our Children's Bureau oversees, but we work very closely with. Heather, I don't know, I might be able to pull mine up. I just am not going to be, I'm not going to see.
That's okay. I think I've almost got it. Let me just.
You got it? Okay.
There we go. Now we're moving. Can you see it?
It just says Heather Hallett.
Oh,
it just, yep.
Sorry, I got it going on my computer and then I forgot to share my screen. There we go. Now can you see it?
Okay, perfect.
There.
Yes, and this is exactly the slide that I was on. So as I mentioned, the have current habilitation sports waiver ends on 9/30/24. So we have submitted the renewal application to CMS. We had a meeting back with them in July, and it was just a general overview of our changes. And right now the review is ongoing. At the end of the presentation, I'm going to provide a more thorough update in terms of where we're at. But just for the time being, I think this is a good start as we go through some of the changes that we're looking at for this renewal. Next slide, please. So with the waiver renewal, just a couple of things to keep in mind that I think are important to mention before we really get started is there may be some of you who are listening to this webinar who are part of our feedback sessions that we had last year. And so that was with all of our 1915C waivers. That's where we got in front of the public, individuals served, their family members, prepaid inpatient health plans, community mental health service plans, those who wanted to attend to get their feedback in terms of what are some things that we should be looking at, what are some things we need to change, update, make better with all of our waivers. So all of the changes that we implemented, most of the feedback came from those sessions. There were some things we knew that we needed to update or we wanted to update just based on feedback that we've received for years and years and years. So I think that's good information to give you all as we move forward with this presentation. So one of the things we heard back from was overnight health and safety. And so we made some revisions to the eligibility and coverage. And what we did is we expanded this service. So we expanded the limit of the service and what it's going to include now, it's supervision for health-related concerns. Sorry, I've just got or it's health-related concerns or in anticipation of a medical emergency. So before this was not covered as supervision you could provide for overnight health and safety. We got a lot of feedback about it and we decided to add that. The other thing that this was something that we've been looking at for quite a while, the elimination of pre-vocational services. We have been monitoring the utilization of this and we have just seen it continue to go down. When we looked at eliminating pre-vocational services, the data that we pulled shortly before we started to make these changes, so it would have been, I think the data we pulled was it would have been in like March. We saw that there were only 9 beneficiaries receiving the pre-vocational services. So, we looked at the definition of pre-vocational services, we looked at the other services we provided, and we felt that removing this service would be the right thing to do for the waiver so that these individuals could transition into similar services like skill building, which is under the 1915 iSPA, and out-of-home non-vocational habilitation. Again, there is a 6-month transition timeframe for these individuals, so they still will be able to receive pre-vocational services when they have waiver renewal gets approved. We will just, be working with individuals and their families to transition those services. We also found in our research that many of the pre-vocational service providers also provided skill building or out-of-home non-vocational habilitative services. So it really should not be much of a transition for those individuals outside of updating the individual plan of service, authorizations looking a little bit different, and perhaps some goals, goal or changes with the goal in the individual plan of service. Next slide. One of the things I'm pretty excited about is the update of our goods and services language. A lot of feedback we received about that the language was restrictive because we had language in there that said that you could only use goods and services if it replaced human assistance. I think it caused a lot of confusion. So we really saw very little utilization of goods and services. So we removed that. And we did that so we could expand the service utilization. So we're really hoping to see the utilization of this service goes up. We also clarified a lot of the language. I think that it makes it a little bit easier to understand exactly what goods and services is for, what it can be used for, and what it cannot be used for. We also added adaptive clothing to goods and services. So with that, we put an overall limit of $2,000 on goods and services overall. So that would include the adaptive clothing per year. Now, in the past, we did not have any limitations on goods and services, but we wanted to be mindful of the fact that we are removing some of where we provided clarity. We're removing what people felt was a restrictive language. So, you know, we wanted to make sure that we were fiscally mindful of what that might lead to. And so we put a $2,000 limitation on that. However, we'll be evaluating that throughout the year to see if it causes any, you know, any unintended consequence, you know, of use or limited use. The other thing we did is for the enhanced medical equipment and supplies, including vehicle modification, there was language in there that said paid providers would be eligible for vehicle modification, and that's not allowed actually under CMS. So we needed to update that and so that it aligned with the technical guidance from CMS. The other thing I'll say that's happened in the interim since we've heard back from CMS is we had to remove vehicle modification from enhanced medical equipment and supplies, and it's going to be it's a service of its own. So it is just going to be independent of enhanced medical equipment. Next slide, please. We did update the supported employment language. What we did is we updated it so that the 1915 iSPA supported employment language would align with this language. We broke down the language into 3 categories: individual supported employment, self-employment, small group employment. We clearly defined each category. So the immediate feedback we got from CMS is that we needed to separate small group supported employment from supported employment. So that's really just sort of a technical separation in our application. I don't think we'll see much of an impact because in terms of our claims reporting, we have, I believe we have a modifier that indicates the separation of small group supported employment. We did get a lot of feedback because we did have language in our application, but for a public comment that talked about putting timeframes on situations where it has been identified that the person is going to have a fade plan with supported employment. It caused a lot of confusion, a lot of concern. So we removed that language, but we are still going to look at having limitations to fade plans because fade plans are not intended to be infinite. So we had to update some of our revisions to our performance measures. So we added some administrative ones, and the first one is related to conflict-free access and planning. So we are looking to ensure that our providers have administrative policies regarding the conflict-free requirements. Again, this one is on hold until CMS approves our implementation plan. So you can expect this next year with our site reviews that we will just be providing technical guidance once we get that approval from CMS. We also implemented a home and community-based services rule. So this is based on the PIHP having effective administrative policies in place regarding HCBS compliance and the monitoring process. Again, starting this year and for only this fiscal year, we will be looking for these things, but we will be providing technical guidance. So if, let's say, a PIHP or CMHSP does not have this policy, we will just make recommendations for them to work on creating a policy, what the policy should entail. The next one is our level of care. CMS did not like our previous level of care performance measure. So this one is going to be the number of % of beneficiaries with intellectual and developmental disability with reasonable indication that waiver services may be needed in the future and have an evaluation completed. So CMS had asked us to be able to utilize a performance measure where we're able to identify potentially eligible have waiver folks and then be able to look at those who were potentially eligible, how many of those were enrolled into the HAB waiver. Currently, we have no way to do this. So we added this as a performance measure. Again, this is going to be something that we will be working with the PIHPs and the CMHSPs to develop a plan and it will be like a reporting requirement. The individual plan of service, so this is with HCBS requirements. that the completed IPOS will have identified restrictions and modifications that comply with HCBS requirements. And then the individual plan of service, the IPOS reflects separation of service planning from service delivery. Again, these two are ones that we will be providing technical assistance on. We will be looking for them this first year of our site review process, but we will not be substantiating any out of compliance issues. It'll just be technical guidance provided. Critical incident reporting also added a requirement, and we wanted to start capturing falls that required emergency medical treatment or hospitalization. So this was only added to the HAB waiver in the children's waiver. The reason we did this is because we want to be able to monitor those individuals that have frequent falls. And then what is the response? Is the response, is anyone making a referral for OT? If the person's has an unsteady gait, is there a referral for OT or PT services? Is there a need for enhanced equipment or supplies? Is there a need for an environmental modification? And so those are the things we are going to be looking at, and our intention is in terms of tracking with that critical incident report requirement. Next slide, please.
Cynthia, there were a few questions. Do you want to answer those now, or do you want to wait until the end?
I will stop and answer, like after I get through the HAB waiver, I'll go through and answer those questions, and then we'll go to the iSPA.
Okay, sounds good.
That works. Okay, perfect. Okay, so a couple of just additions, language changes is there was something with environmental modification language, and there was a nuance in there that the person had to find alternative housing. We removed that. That was a little bit it was restrictive, and so we removed it. We did update respite services. We wanted to expand the provider category, so we included licensed children's therapeutic group homes, licensed foster family care, or family group homes, and I believe that was added with all three waivers. I'm just not 100% certain if it was already in the children's waiver, so it could just be a HAB waiver addition. I apologize that I didn't put clarification of that one. We did change the frequency of provider qualifications from 2 years to 3 years. So this was a big one we heard back from our providers. The reason we did this is we had other credentialing agencies that only required this to be every 3 years. We were sort of the unique entity that was requiring every 2 years. So it was creating some administrative burden. So we did this to align with other credentialing agencies and to create administrative efficiencies. We also changed the site review frequency from biennial to annual. And so this is for the all 1915C waivers. We also did it for the 1915 iSPA. So again, this was CMS request of us. This is a huge lift, we understand. Not one that we at all were prepared to make changes on. We are getting prepared, however, though. But again, this was something CMS said we needed to do to ensure that we had good monitoring and oversight of our PIHPs, our CMHSPs, and our service provisions in the state of Michigan. So we will be implementing this in FY26. So the next year we'll sort of be prepping for this change. The biennial review will still continue this year with only the 5 PIHPs who are normally on the rotation. Next slide. So there was some language in our criminal history check that said performed by the Department of State Police. So we removed that because it was not accurate. We also made a terminology change. We changed fiscal intermediary to fiscal management services. It's just new terminology that if you're involved in self-directed services or in that area, this is a terminology that's being used at a national level. We did update the home and community-based services implementation language. So we updated this language to reflect modification requirements in the individual plan of service. And we updated the language to reflect the monitoring and compliance requirements related to the home and community-based services rule. We also updated the electronic visit verification language. So again, the language that was in there before was reflective of 5 years ago where we were at with EVV. So we updated the language to reflect where we're at now and what those requirements are. We did update the conflict-free access and planning requirements. So we aligned what I it's interesting because I have this information in this presentation because I made a similar presentation at the SD conference, and we have had changes since then. So what I will say about this, because we did have CMS feedback, there is language in there about the approved conflict-free access and planning scenarios outlined in our requirements and in the PIHP contract. There's language, I believe, that is still there, but what we've added per CMS's request is actually further detail and requirements for conflict-free access and planning. We also added the new HUDOS 2.0, so that'll be the assessment screening tool that we will be using for the adult IDD population. So there was a question in there. In the past, we have checked off that we would do consolidated reporting, which simply means that we would send CMS one report for all three of our 1915C waivers. It's interesting we had that checked off because we never did that. We always submitted 3 separate reports. So we did look at that. We did look at, well, gosh, would that save us time? And really, in an effort with all the things we had going on, we just decided to do consolidated reporting for each of the waivers. But we may elect that in the future. It would just be a change, and we weren't sure that we were quite prepared to make that change at this time. Another thing that we did is we expanded the eligibility group to TEFRA. So that's the Tax Equality and Fiscal Responsibility Act of 1982. So this is related to children who qualify for Medicaid through the TEFRA program. So again, in the past, this was a group that was not covered. And so we wanted to make sure we added that group. And finally, I think it was important for me to mention all of the things that were provided during our feedback sessions that we did not implement. So the first one that we heard an overwhelming response to was the enhanced therapy services, art, recreation, and massage therapy. And what I will say is we don't disagree with these recommendations. In fact, I think that is a great recommendation and one we were truly hoping we could implement. Unfortunately, we just did not have the time. Adding a new service to any of the waiver does require legislative approval. We do have to look at the financial impact to ensure that our community-based costs are less than institutional costs. And out of curiosity, if anybody wants to know, we get our institutional costs from the state of Ohio because we do not have any institutions in the state of Michigan. So we are still looking at this and pursuing this. I'll be honest with you, we haven't been able to do any work on all 3 of these just because we've been so wrapped up in getting this waiver renewed. But we are committed to continuing work on this. And if we are able to get this service added via an amendment, it is our intention to do so. Worst case scenario would be it would get added at the next waiver renewal, but that's not our goal. Our goal is to get this added before then, but I certainly can't make any guarantees that that's going to happen, but it is definitely something that we are invested in. The other thing is moving personal care into behavioral health for those individuals or case managers who have to try and live between the home help, CLS. It can be very burdensome. And so we are also looking at that. Again, we needed more time to get that implemented. So that is also on our agenda to pursue once we get through the waiver application and approval. And that, of course, would be done through a waiver amendment. And then finally, one of the big ones was allowing responsible relatives to provide CLS care. This was one we were charging forward with, and I felt probably about 99% confident we would be able to get that in there. But we started to do some research in other states that have implemented this just to see how they implemented it, if they had any issues, concerns, and Indiana had implemented it. And it ended up, they had it for a year. I think they were like, I can't remember the exact amount. It was like $1 billion. I thought that they were in a deficit because they just didn't anticipate the increase in the CLS care requirements. And so they ended up having to take it back. I think they offered some like a a rate, like a daily rate for parents. But so this isn't off the table. I just got some information about Utah adding this, so we're going to take a look at this. We just really need more time, because I think one of the things we didn't consider, because we didn't really think it would increase CLS costs, but I think it will, because what we don't know is that kind of the care that responsible relatives are providing that is unpaid. So it's sort of that natural support. And so how do you accommodate, or how do you sort of define what natural support is when it's not anything that gets reported up to the department? So I think that's the work that we need to do in that area in order for us to come up with an accurate perception and cost of moving responsible relatives in there, and also just to ensure that we have some firewalls in there. Not that I think anybody is going to intentionally commit fraud, but we don't want anybody to inadvertently commit Medicaid fraud either. So this is the pause. I see I have 6 questions, so we're going to pause here. 7. Here they come. Let me see what time it is. I just want to make sure. Okay, so I think if I answer questions for about 5 minutes, and then we get to the I can answer questions after that. So let's see what I have. Yes, so the small group for supported employment, it does define the number, but Brittany, I cannot remember what that number is right now. But it is defined, and I believe if it's not defined in our language, I think it's defined in the code chart. Or it will be defined in the Medicaid provider manual language. I just can't remember what that number is. What update to conflict-free access and planning can be provided, particularly to, I don't have any updates right now. The language has been submitted to CMS, so until we get a response and approval from them, I don't feel very comfortable sharing any of that information because it's technically not official. So once it is official, that will be shared. And again, that's not an area that I am overseeing. It's just involves some of the work that I do in federal, well, much of the work I do in federal compliance, but it's not an area I lead or I oversee at this time. What is meant? Okay, what is meant in anticipation of a medical emergency? A medical emergency, sorry, I think that was related to fall. So that would be like emergency medical ED treatment. So it's the same thing that when you have like a medication error or an injury, when you take someone to the ER, there's emergency medical care. Although that is a great question though, Beth, because we have had some ask for clarification of that. And I think it's probably something we should look into when we, because I think we just word it emergency medical treatment. But I do think, you know, like we should define, like, does that include urgent cares? Does that include emergency departments, things of that nature? And I think that's work we can do in our critical incident reporting group. So that's a great question. We cannot consolidate the My Choice waiver and the habilitation supports waiver because they're 2 distinct C waivers. They have different, like the My Choice waiver, for example, has different qualifications for enrollment. You have to have nursing level home of care. The HAB waiver has institutional level of care. There's also differences in terms of the, so the eligibility is different. I think the federal income poverty level is different. There's lots of differences. So there'd be no way to consolidate those 2 waivers. I think we'd in fact take away services if we did that. If moving personal care into behavioral health in the future, is there still an expectation that home health will be around? Yes. So great question. Another great question. And that was sort of our pause, to be honest with you, Brittany, is that home help is a state plan service. So the C waivers can't prevent or prohibit somebody from getting state plan services. So in theory, somebody still could receive home help if we moved in personal care. I don't know that anybody would want to do that, but again, we're at the beginning stages in talking about that. But that was one of the things that we needed to distinguish why personal care would need to be, and again, this was just the C waiver in terms of looking at personal care, but yes, and that is one of the things to look at, the prevention of duplication. I mean, honestly, I think EVV would assist in preventing duplication. So someone wouldn't be able, like, let's say we were able to move personal care into behavioral health. EVV would be one of those components that would be able to ensure you weren't getting paid for home health and you weren't getting paid for behavioral health and personal care. So allowing responsible relatives to provide CLS is not a, it is a service. I think it says was not a new service maybe, and was added to my choice waiver. Yes, I'm aware of that. Can you borrow whatever work they have done? Yes, we can, and we have looked at what my choice has done. In fact, we were looking at that. I think one of the biggest components, because we were, of course, working with our other C waivers, and it's not really a component of my choice, because the populations are so vastly different as we were dealing with children. And then there is also a component of parent responsibility, and that CLS services cannot supplant a parent's normal responsibility. We have been wondering if not allowing responsive relatives to do this work runs afoul with HTBS. I mean, to do this work runs afoul of the home and community-based services rule prohibition on the conscription of relatives or other informal supports to do unpaid work. I'd have to look into that further. I don't recall anything in the HCBS final rule, but it doesn't mean it's not there. About the prohibition on the conscription of relatives or other informal supports to do unpaid work. That's definitely something to look into, but I'm not familiar with that at all. The HUDAS will determine eligibility. What tool will be used to determine level of care? So the HUDAS will be used more like a screening tool, and for the HAP waiver, it will be used to determine eligibility for the 1915 iSPA. The level of care, so we will still use information from the HUDAS, but we're not, in terms of the requirements for that level of care and that redetermination, so the initial enrollment and the recertification, we have not changed those requirements. They are still going to be the same. So we use the FMLA, which is the functional, oh my goodness, my brain just, functional activities of daily living, I think it is. Sorry, I cannot remember the acronym right now. I apologize. I'll probably remember it at the end of the session. But we'll still use all of those same tools that we have been using in the past. The HUDAS will just supplement that and provide additional information. Oh, Jill, so 4 to 6 people for small group employment. That sounds about right. Thank you. Can you speak to the anticipation of medical emergency in the context of overnight health and safety? I hope I answered this question for you correctly. Oh, thank you, Susan, for sending me that information. So before, overnight health and safety would not cover. So you probably would have used CLS with the appropriate modifier, but it wouldn't have covered care for somebody who may have an anticipation of a medical emergency. Heather, is there a way you can go back to that slide just so I can see the language, just to make sure I'm answering her question correctly? I think it may be one of the first slides or first of the changes. Okay. Oh, it was that last one you were just on. Okay. Yeah. So before if somebody had an anticipation of a medical emergency, you could not use overnight health and safety. And so we ended up clarifying that language in the waiver renewal. And that's in all of the waivers, I should say, all of the C waivers. All right, so I think I got through the questions, so I'm going to go through the I. And again, I may have to sneeze, so I apologize if I mute myself and sneeze. It might be okay. Okay, so we amended the 1915 iSPA waiver, of course, to align with the waiver renewals. So the 1915 iSPA does require both tribal and public comments, so that has been completed. The amendment is being reviewed by CMS. Again, I'm going to give you guys an update at the end of this presentation in terms of where we're at right now. And again, I said this, like, not only did we amend the 1915 I waiver to align with waiver changes, and that's all the waivers, because 1915 I serves both children and adults, but we also used it as an opportunity to make some other changes, and we'll go over that with this presentation. Next slide. So again, we added the HUDOS 2.0 in the Michigan. So in the previous application for the 1915 I, we had the CIS, the CIS-A, and we also had PECFAS and CAFAS. So those have been removed, and we've added the HUDOS and the Michigans. Same thing, and again, I don't know if I mentioned this, but the name change from fiscal intermediary to fiscal management services, that was across all of the C waivers and the 1915 I. The change in provider qualifications. So many of these are kind of across the board with all the waivers. I should have probably mentioned that at the beginning of this slide. The provider qualifications from 2 years to 3 years, that again was across the board. The change in the site review frequency from biennial to annual, that was across the board. So again, all C waivers, 1915 iSPA. Next slide. Thank you. The update in the conflict-free access and planning language, that again was across the board, all of the waivers, all of the 1915 I. Now, the revision to supported integrated employment, that was only the HAB waiver in the 1915 I. Again, CMS feedback was we need to separate the small group. And again, this was really aligning the language and then breaking it down by the 3 categories. So one of the changes in the 1915 I that ended up requiring another, and not to be confused, but a state plan amendment was what we did is we took the parent support partner from family support and training, and we moved that to the state plan. And the reason we did this, so it was in the SED waiver, it was in the 19 iSPA, we moved it to the state plan, and that was really just to allow greater access to the service for all beneficiaries. This, having services in the state plan does not require an eligibility or an enrollment into a waiver of the 1915 I. So once someone qualifies for Medicaid and for community mental health services or behavioral health services, the state plan is, they are eligible for all state plan services. So again, just greater access. This is one of the exciting ones I feel for the 1959. As I mentioned, we tried to get some updates that we needed. So this was a big one that we heard back from our providers, is that our qualifications, our staffing qualifications and provider qualifications for the housing assistance was really too restrictive. It was very difficult for our providers to get to find staffing for this service. So the 1915 I team did a great job. They worked with some of our housing support group within the state of Michigan. They worked with them, did some research in other states in terms of what were their provider qualifications. And so what we did is we added additional qualifications to the pool. So we added a direct support professional, a certified peer support specialist, and a certified peer recovery coach. And so those 3 qualifications were added. And in addition to having those qualifications, they must also have 2 years of experience providing services to tenants in supportive housing or other social services setting or lived experience. So they need at least those 2 years along with those other qualifications in order to provide this service. And this really did align with what other states were doing. So we're hopeful we'll start to see an increase in the utilization of the housing assistance once this 1915I amendment is approved. So with the revisions to vehicle modifications, so we added that, so keep in mind the 1915 iSPA, it has a separate code for vehicle modifications, which that will be also for the HAB waiver. So that will be a change that our providers will see, is that this is a separate code. But the language that was added, and again, aligns with the HAB waivers, that the vehicle that is adapted may be owned by the individual, a family member with whom the individual lives or has consistent and ongoing contact, or a non-relative who provides primary long-term support to the individual and is not a paid caregiver. And I want to focus on that because I think it's important to think about this, because if we were to add the responsible relative or somebody who provides natural support, there would be this would be one thing that could impact their ability to have their vehicle modified once they become a paid provider. So it's just something to kind of keep on everyone's radar. Again, that is if we were able to move into that responsible relative being paid to provide CLS services, but just I think it's important to make that distinction and provide that clarification. Next slide, please. So revisions to skill building, we had a lot of feedback. So this was another one that even though it's not part of any of the C waivers, we thought we need to make some updates on this. We've gotten a lot of questions about this. So we added clarity regarding the service. So again, medical necessity for skill building or CLS. People had asked like, well, what's the difference? They read very similarly. How do you know when to use skill building? How do you know when to use CLS? So we hope that the language changes we made provide that clarity. We also kind of separated the emphasis of skill building. So one emphasis is on developing and teaching skills that lead to competitive integrated employment. And then again, the other emphasis or pathway is develop successful skills to engage in meaningful activities such as school, work, or volunteering. And so we thought that would be helpful to add that. And then we did some language to competitive integrated employment to talk about the developing and teaching skills that would lead to this. There is also a service time limit with a primary focus on skill development, acquisition, retention, or improvement in self-help, socialization, and adaptive skills. So we, again, provided some clarity in the language that we thought was needed just based on the feedback and the questions that we were getting, that our employment specialist was getting. We did add language regarding the ability for individuals who are still in school that they may still receive skill building and other work-related transition services through the school, while also participating in skill building services within the community mental health agency. Really, this should be designed to complement and reinforce what they're learning in school, and only should be provided during the times that the school is or the education system is not responsible to provide skill building. Next slide. Okay, so I'm going to go through this update and then I'll take the rest of the questions if that works out. It looks like we have plenty of time. So the process in which CMS reviews our C waiver applications and our 1915I is they first make a request to us, which is called an informal request for additional information. And that, again, was for all of the 1915 C waiver services and the 1915I. CMS, the iSPA, gosh, I can't remember how many pages the iSPA had. Not nearly as many as the C waivers. But the C waiver, so the HAB waiver, which I'm more familiar with because it's under my section, had 17 pages from CMS, 17 pages that CMS asked us to provide further information on, further clarity, make changes. I believe the other two C waivers had like maybe 13 or 14 or 12 or 13. It was something like that. I think the iSPA, and I should have checked this before I did this presentation, that may have only been like 5 or 6 pages. Again, it didn't have as many as the C waivers. So as you can imagine, that took us quite a bit of time to go through. We finally were able to get through all of the informal requests, the additional information, and we submitted that to CMS last week. What I'll say in general about their request for information is, yes, they had questions on some of the changes we made, but many of their questions were based on our oversight of the system and how we were doing that, and what exactly we were doing to ensure that all of the requirements were met. And so, you know, it really was an opportunity for the department to sort of take a look at that and think about where are some changes, what sort of changes we need to make. They did scrutinize several of our performance measures. We in fact had to remove 2, and again, I'm speaking from the habilitation supports waiver, not the other 2 C waivers. We did remove 2, and we had to replace. We removed 1, and we had to replace 1. You know, that was something that was interesting. And they really, like one of them, they asked us, they said we could replace it. And it was really restrictive. I was a little bit shocked by CMS's requirement, but you know, it was something to the effect of, if the, you know, provider isn't compliant, they are removed from the provider network. I think that kind of leads, you know, this audience to understand, like, you know, sort of where CMS's perspective is in their review of this. So CMS will take their review again. They've had it. Gosh, it's been less than a week, and they'll decide if a formal request for additional information is required. If that is required, then we will have to extend the C waivers. And keep in mind, the iSPA amendment will align with the waiver renewal. So we're sort of in limbo right now. We provided them all our responses. We're just waiting for CMS to respond back. So if we do have to extend the waiver request, we will send a formal letter to CMS requesting that. Any waiver renewal requests are for 90 days. And during the 90 days, I don't believe you can make any changes. So we couldn't do any amendments, let's say, if we wanted to in that 90 days. And so the previous waiver would stay in place, and the new waiver would not begin at least for another 90 days. And again, the iSPA, CMS has already told us that they'll hold that iSPA amendment to align with the waiver renewals. But, you know, I suppose anything's possible at this time, you know, because I know that there were some changes with the iSPA that had implications on additional services being added to our state plan. So right now, we just need to wait and see what CMS says. And I only have 2 questions. So, will there be self-directed services parent support partner? So there is the parent support partner, but not anything specific to self-directed services. That's the first time I'm hearing of that. I mean, I suppose, we don't have a service called self-directed services parent support partners, but we do have parent support partners, and I would presume that they could be part of, you know, that they could assist in self-directed arrangements. I honestly would just need to look at that language. Again, the parent support partner section area is not an area that I oversee. And now that I think about it, I would have to look to see if there's an age limit on there. Again, not my area of expertise, but an interesting question. One I'd have to follow up with. So skill building, gosh, Beth, I have to try and remember. I think that if I recall, there will be a limitation on that. We did not define the time limitation. We are still in discussions about that. We're trying to be very careful because we don't want to put something in there that ends up being more detrimental than helpful to the individual. So there are no defined time limitations as of yet, but they will be defined in the Medicaid provider manual. We're still working on that. Yes, TEFRA. So here's the thing. TEFRA, so what TEFRA allows, okay, good question. So individuals who are on TEFRA are eligible for Medicaid services. So they would still need to enroll, or they would need to go through the process of enrolling into behavioral health services, have the intake and the screening completed. What the change that we made with the HAB waiver is that those individuals who have TEFRA that qualifies them for Medicaid goes through the intake and screening process at the behavioral health level and is deemed that they are eligible for services for behavioral health, can, once the waiver is approved, can also be determined, see if they're eligible for the HAB waiver, and then go through the enrollment process for that. Currently, right now, TEFRA individuals cannot be on the HAB waiver. They can still receive behavioral health services through the 1915I, but they cannot be on the HAB waiver. Oh, TEFRA, out of my area. I don't think it is a department within MDHHS. I don't think it's Children's Special Health Care Services. I think it's a whole separate department. I'm going to have to get back with you on that one, exactly who it is. I was hoping I'd be able to remember, but it's not coming to my brain right now. It is definitely a department at MDHHS. I just cannot remember the name of it.
Okay, so that is all the questions that we have, but maybe we'll give a few more minutes if people want to have a last minute question. But just as a reminder to everyone that Zoom will send you a follow-up email with a link to the recording from today's presentation. And then I will send a follow-up email with a PDF from today's presentation, as well as a link to our previously recorded webinars in this series. So I think that's all that we have for today. Linda, do you have anything else?
Just thank you, Andrew. And I'll let you know, I should have mentioned this, so I apologize. So Andrew, thank you, because you spurred my memory. We will be providing additional technical guidance and training on the waiver changes. We haven't made any formal plans, at least in my section. I think the Children's Bureau may have more formal plans. We're just kind of holding off and waiting for CMS, and then we're letting that sort of inform our plan and where we would where we're going to go with that training. But yeah, I'm glad that this was helpful, and there will be more of these to come that will be directed to, for our CMHSPs, PIHPs, and if needed for the individuals served too. So again, thank you for triggering my memory with that comment.
All right, I'm not seeing any other questions, so I think we're good to end the webinar for today. And just remember, you will be getting those follow-up emails and with the link and with the PDF. Thank you all so much for attending today. We hope to see you back next month.